Dr. Agu, please go ahead. Unmute yourself.
Okay.
We can hear you now.
Can you hear me now?
Yeah, we can.
Okay. A 60-year-old man, known hypertensive, presenting complaint, difficulty in breathing, productive cough, PND, bilateral leg swelling, irregular pulse, biphasic repetitions, tender hepatomegaly. What's your diagnosis? My diagnosis is congestive cardiac failure, secondary to chronic hypertension, preceded by arrhythmia and community-acquired pneumonia. Next slide. List modalities. We'll do a chest X-ray and cardio using echo. But the grading of heart failure using echocardiography, you can grade using the left ventricular ejection fraction. So the grade 1, heart failure with reduced ejection fraction. In these patients, they have left ventricular ejection fraction less than or equal to 40%. Heart failure, the second one is the heart failure with preserved ejection fraction. They have left ventricular ejection fraction greater than or equal to 50%. And then you have heart failure with mid-range ejection fraction. These patients have left ventricular ejection fraction 41 to 49%. Kind of referred to as improvement in ejection fraction. Now, 4 classes of heart failure medications with examples, class 1 evidence, have the angiotensin converting enzyme inhibitors or ARBs. Examples, enalapril or angiotensin receptor neprilysin inhibitors like sacubitril/valsartan combination. You have the beta blockers like bisoprolol. You have the mineralocorticoid receptor antagonists like spironolactone. You have the sodium glucose cotransporter 2 inhibitors. Example is the empagliflozin. I think that's the end of my slides. Thank you. Hope I'm still audible.
Yes, you are.
Okay, sir. Thank you. That's the end of my slides.
Okay. We thought you have a little overview on heart failure. By the way, thank you for the presentation. I think the floor is open for contributions, comments, and other things. But let me just read out what is in the chat first. Dr. Ozo said 40 to 49% is no longer a mid-range, but mildly reduced ejection fraction. So one of the classification that you said mid-range, 40 to 49, he said it's no longer mid-range, but mildly reduced ejection fraction. Then again, Dr. Ozo said again, the ejection fraction increase following treatment is recovered or improved ejection fraction. Totally different from the mid-range. I think if he's in the house, he can add more explanation to that. So those are from the chat.
Okay, good morning, everyone. Okay, good morning, everyone. Yeah, thank you so much for your thanks so much for your beautiful presentation. Okay, so I just want to add on to what he just said about classification of heart failure using echocardiography. Okay, so basically what Dr. Ozo was trying to say is that it can actually be graded using the ejection fraction, which you said. So we have heart failure with preserved ejection fraction, where the ejection fraction is actually greater than or equals to 50%. Then we have heart failure with mildly reduced ejection fraction, where the ejection fraction is 41 to 49%. Then we have heart failure with reduced You know, that mid-range you called is actually what it's now classed as mildly reduced, no more mid-range. So that's what Dr. Ozo was trying to explain to you, which is 41 to 49. Then heart failure with reduced ejection fraction is 40 or equals to or less than 40%. That's heart failure with reduced ejection fraction. Then we also have the fourth classification where we have heart failure with improved ejection fraction, meaning that the ejection fraction was initially less than 40, but with heart failure regimen being given to this patient, maybe you repeated the echocardiography 3 months or 6 months thereafter, the ejection fraction then increased. So that's what we call heart failure with increased ejection fraction. So we actually have 4 classifications: heart failure with preserved ejection fraction, where it's greater than 50, equal to or greater than 50%. Heart failure with mildly reduced ejection fraction, which is 41 to 49. Heart failure with reduced ejection fraction, 40 or less than 40. Heart failure with improved ejection fraction. Initially, it was 40, but after the antifailure regimen medications, it then increased to 40. So such patient is still in heart failure, but it's just that the antifailure regimen actually increased the ejection fraction, maybe improved the ventricular filling effect. And then when the echocardiography was repeated after 3 months or after 6 months, it then improved. Then also we have what we call the Fantastic Four of heart failure, which that's the heart failure cocktail that we use. He has mentioned it, but I just want to lay emphasis on it. So we actually have the class 1 from the Fantastic Four. We actually have the first line, second line, third line, and then the fourth line. So we have what we call the sodium glucose cotransporter 2 inhibitor, which is the SGLT2 inhibitor that he mentioned, where we have the empagliflozin, dapagliflozin, and all. Then we also have the second class, which is renin-angiotensin system inhibitors. So that's where we have the ANI, we have the ACIs, we have the ARBs. So basically what we do in these renin-angiotensin system inhibitors, we start most times with ANI, which is the sacubitril valsartan, that's the Uperio, that's the trade name. But it's just that it's quite expensive. And then some people can't take, they present with hypotension, they present with dizziness. So most times when you place them on that, most times their blood pressure can't take it. So if the patient is not tolerant to that, you can now step down to the ACIs. But if the patient has cough or maybe is reacting to the ACIs, then we can step down to ARBs. So for under the renin-angiotensin system inhibitors, that's where we have the 3 drugs, the ANI, the ACIs, and the ARBs. So the third Fantastic Four medication is the beta blocker. But beta blockers are actually given when the patient is out of that acute state of heart failure, because we actually need a sympathetic drive. But basically, let's have at the back of our minds that for heart failure medications, we have beta blockers, where we have the bisoprolol, we have the atenolol, we have the carvedilol, we have the nefibolol and all. So those ones are actually cardioselective, meaning that you can actually give them to patients who are asthmatic. It doesn't really act on, I think, the beta-2 inhibitors, beta-2 blockers. Then lastly, we have the mineralocorticoid inhibitors, where we have the aldactone, we have the triamterene and all. So those are the medications we give. So we call them the Fantastic Four: SGLT2 inhibitors, renin-angiotensin system inhibitors, ANI, ACIs, ARBs, beta blockers, and then the mineralocorticoid inhibitors. So these are the Fantastic Four medications for heart failure. That's the pharmacological interventions for heart failure. Thank you so much.
Thank you for this
wonderful.
Thank you
very much, Chief. Thank you very much, man. I really appreciate it.
Make things clearer. Thank you. I think from the chat again, Dr. Mamodu said, thanks so much. Kindly outline the ACC, AHA stages of heart failure and what's this patient's stage? Are you going to respond to that? Hello, Dr. Agu. Dr. Agu. Then Dr. Temitope said, said, kindly outline the ACC, AHA stages of heart failure And what's this patient's stage? Then Dr. Temitope said, at what point do community-acquired pneumonia in the clinical scenario provided? What made you to think of the diagnosis of congestive cardiac failure secondary to systemic hypertension preceded by arrhythmia, as you said, and community-acquired pneumonia? She wants to know what made you think of precipitant as community-acquired pneumonia from the question. Maybe you start responding to that first.
Okay, can you hear me? Am I audible?
Yes, we can.
Okay, I think from the question, you know, what they painted, they painted an image of, let me read the question again. They said the patient had, just give me a word. Okay, so they said a 60-year-old man, known hypertensive. So the patient, they gave us a history that he's a known hypertensive, presenting complaint, difficulty in breathing, productive cough, PND, bilateral leg swelling, irregular pulse, bibasal crepitations, tender hepatomegaly. So I think the patient had features of both right-sided and left-sided, failure. That was why I had to.
No, her question was towards why do you think of community-acquired pneumonia as a precipitant of the heart failure in this scenario? Is it because of the bibasal crepitations and productive cough, which can be seen in a patient without features of community-acquired pneumonia in the setting of heart failure? Maybe she wants more clarification for that.
Okay, can I come in here?
Yes.
Okay, so basically for bibasal, it was actually fine crepitations, right? So when we have bibasal fine crepitations, what the patient has is just basically pulmonary edema. Is when you have coarse crepitations, you're thinking of a chest infection. So I don't think a precipitant here is what they call it, chest infection. I think it's basically just leave it with heart failure secondary to maybe hypertensive heart disease precipitated by cardiac arrhythmias. You understand? Or AF, cardiac arrhythmia for AF. So bibasal fine crepitations just tells us that there's what pulmonary edema, not a chest infection. There has to be a coarse crepitation for you to say there's a chest infection. Thank you.
And Dr. Olalekan is saying ARNI is recommended for heart failure with reduced ejection fraction, and SGLT2 is recommended for all classes of heart failure, even those with reduced, mildly reduced, or preserved ejection fraction, and it's class 1 evidence. Dr. Mosope said carvedilol is not cardioselective. Yes. It also has both beta 1 and beta 2 blockade. Dr. Cassidy said, thank you. Will have precipitated the heart failure. Why the choice of cardiac MRI over ECG as part of the 3 investigation for this? So Dr. Agu, Dr. Cassidy said, what type of cardiac arrhythmia will have precipitated the heart failure? And why the choice of cardiac MRI over ECG as part of the 3 principal investigations for this patient? Why did we go for cardiac MRI and leave ECG behind? Hello?
Dr. Agu is having issues with his network.
Okay.
Can I?
Yes, you can come in.
Okay, I think, in hierarchy, since this patient actually has an arrhythmia, a cardiac arrhythmia due to the pulse, ECG should be amongst the first investigations to be done, but notwithstanding, cardiac MRI is more diagnostic when we actually want to measure the ejection fraction. I think that's the best investigation to be done, but common things come first. So I think I would, in hierarchy, I want to start with an ECG. to back up my evidence, to know what kind of cardiac arrhythmias this patient has, whether is it atrial fibrillation, is it flutter, is it whatever kind of arrhythmias this patient actually has. So I think ECG should be put up there. But if they are telling us to mention maybe 3, I think we can go further to mention more than 3, because the cardiac MRI is actually what gives us the best diagnosis to check for left ventricular ejection fraction, especially when we actually have to grid the heart failure using ejection fraction. So it's not bad putting the cardiac MRI, but the ECG should be amongst the first because of the irregular pulse to back up the evidence of using ECG. So thank you. ECG should be there.
Okay.
It should be there.
Dr. Florence.
Yeah, thank you, ma. Noted, ma.
Yes,
Dr. Ago, people
yes,
didn't see the question. They said imaging modalities, or was I wrong?
Okay,
that was why I was raising my hand too. That is imaging.
Okay, I didn't see the question. Then the patient, he's right by putting cardiac MRI. He's actually right.
Because the questions are two. One said imaging modalities, then the other said 3 other cardiac specific investigation. I think that's why he put cardiac MRI.
Okay. He's actually right on what he wrote down. Thank you.
So somebody is saying again, how will you tackle the arrhythmia in this context of heart failure?
Okay, the arrhythmia in the context of this heart failure. Well, first of all, I have to do an ECG. So when I now do the ECG, I will note the kind of arrhythmia. Is the patient having presence of premature atrial complexes or premature ventricular complexes? Are we looking at atrial fibrillation, atrial flutter? I would want to look at the P wave and the PR interval. And of course, I want to rule out presence of delta wave, to rule out, the presence of, accessory pathway in this patient. Now, if I've looked at it and, we're dealing with APCs, in this patient, well, some school of, I don't know, I have worked with one of my profs. He would suggest, if the patient is having maybe atrial fibrillation with fast ventricular response, you could try low dose beta blockers. You start from low dose and titrate up based on patient's response. You could also give amiodarone in these patients. You can give amiodarone. Of course, you have to do your transesophageal echo to rule out presence of clots, in the left atrial appendage, and then you give your amiodarone in this patient. I think those 2 options, I will go with them. And with regards to the arrhythmia specifically, and then if it's a ventricular tachycardia, I would also consider amiodarone in this patient. Of course, if the patient has hemodynamic compromise in this setting, although they didn't put the blood pressure, I would want to go ahead and do a DC cardioversion for the patient. If the patient has VT or atrial fibrillation with hemodynamic or any malignant arrhythmia at all, I would want to go straight to DC cardioversion, irrespective of presence or absence of clot in the left atrial appendage in this patient. That's how I approach the arrhythmia. I don't know if there are other things to be added.
Okay, good morning, my teachers. I'll just like to say something about what you just said. Okay, so I think whenever you're asked how will you take care of the arrhythmias, it would depend on the kind of arrhythmia you're having. It will also depend on the hemodynamic status of that patient. For example, if the patient has atrial fibrillation, your treatment or management of that patient will depend on 1, the patient's hemodynamic stability, and then 2, what you're trying to achieve for this patient. So if the patient comes with hemodynamic compromise, then you'll be going for trying as much as possible to anticoagulate your patient and do a DC cardioversion. If it's in a very severe state, you will just need to go for a transesophageal echo, make sure there's no clot in the left atrial appendage, and then you go ahead to DC cardiovert your patient. But if the patient came in a state where the patient is hemodynamically stable, then you'll be looking at, am I going for a rate control? Am I going for a rhythm control? Then the anticoagulation, and of course, later on, other forms of treatment like the ablation and other therapy, even the device therapy that can be put in the left atrium. So if you're doing a rate control, then you now go for your rate control medications. You can use a beta blocker. You can use other of your drugs. Even amiodarone can control rate and rhythm. Then if you're going for rhythm control, which also depends on the type of AF the patient has, which currently we have the new 4 classifications. So it depends on the kind of AF the patient has. You decide, is rate control, rhythm control going to be my achievement in this patient? And if it's rhythm control, you go for your antiarrhythmic agent, which you call them, which can be, and then for the amiodarone, a thyroid function test is important before you go ahead with the drug. Then of course the anticoagulation part comes in, where you can actually anticoagulate your patient and use any of the anticoagulants that you prefer. Then other forms of treatment, which we have already mentioned, you can do an ablation, you can put a device in the left atrial appendage, and all that. So it basically depends on the state my patient came in. Then what am I trying to achieve? Can I achieve both a rhythm and rate control in this patient, or can I achieve just a rate control in this patient and forget about rhythm control? All of these have guidelines that it depends on what you see in your patient, that you will know, would I be able to achieve rate and rhythm, or maybe depending on the classification the patient falls in, find out if the patient has other types of arrhythmias, and of course treat accordingly. So I think a good opening statement is, it depends on the state my patient came in and the type of arrhythmia and what I'm trying to achieve. All right, thank you.
Okay, I just want to add.
Thank you very much, ma. I appreciate that.
Okay, thank you so much. I just want to add one or two to what Dr. Chineme just said. Okay, there was a statement he made that he would like to do a transesophageal echo before you comment on amiodarone. No, we don't do that. It's only when you want to do a DC cardioversion that you actually check for a clot, doing a transesophageal echocardiography. So you don't need to do that. You just check the thyroid function test of this patient before you actually have to comment, so that you don't worsen the state of the patient. Then again, for anticoagulation, we have valvular AF and non-valvular AF. So when the patient actually comes down with atrial fibrillation, please let's try and request for an echocardiography to know what type of AF this patient has. So if this patient has a valvular AF, meaning that there's a form of stenosis, moderate to severe stenosis leading to AF. AF most times is formed when the atrium is actually dilated. And then what happens is that there's backward flow of blood, or there's pulling of blood in the atrium. So the atrium does not contract, there's weak contraction, it doesn't contract properly, and then brings about atrial fibrillation. So you want to know, is it a valvular AF or a non-valvular AF? Is that as a result of the valve being stenosed, or just from other causes of AF? So for non-valvular AF, we can give the oral anticoagulants. You can give all the abizapam, we can give the rivaroxaban and all. But for valvular AF, we give warfarin for valvular AF. So meaning that if there's moderate stenosis or severe stenosis causing the AF, this patient will benefit from what we call warfarin. Then again, to add on to what Dr. Chineme said, we can actually give antiarrhythmic drugs for arrhythmias, but there's a normal question they ask that for structural damage, if there's a structural damage, which do you prefer between flecainide and amiodarone? If there's no structural damage, which is better? If there's no structural damage, you can actually use flecainide. If there's structural damage, you can actually use amiodarone. So like to distinguish between two of them, which do you use? Maybe they can ask further questions between flecainide and amiodarone. So if there's structural damage, amiodarone is preferably used. Then if there's no structural damage, flecainide can be used in such a patient. Thank you so much. So please let's not forget to send for echocardiography with the patient with AF to know what type of AF this patient has. Thank you.
Thank you very much, ma, for the comments, ma. I appreciate it.
Okay, I don't know whether our teachers have one or two things before we move to the next presentation.
I just have a comment. Yes. Dr. Yahaya, I just have a comment. I don't know if I want to make a comment later. I must appreciate Dr. Florence, Dr. Chineme. They speak so clearly, so lucidly. Dr. Florence, are you going forward in SSR?
Yes, ma'am.
October or May?
October.
You're just speaking like a fellow. Congratulations. Love the way you speak. So clearly.
Thank you. Thank you very much.
Please, let's be hearing your voice.
She's the one I've been telling you about.
All the people you've been telling me about, they are all represented. Ruka represented very, very well. And so far, she's representing already. Keep recommending them to me, I beg.
Yes, Chief Florence Ba. She's our group rep for the next class in cardiology.
She's good. She's good. Keep it up, please. Keep it up.
Thank you, man.
I just wanted to make that comment. When people are good, don't say behind their back. Let them know they are good. So, Florence Chineme, at least Chineme now has a companion. Now that Ruka left. So, thank you so much. The cardiologists, thank you. Cardiologists in the house, thank you. Dr. Ozo and every other person that contributed. Thank you. And if I miss any name, please just bear with me. Thank you so much. I appreciate your input. Thank you. So, Yahaya, over to you.
Yes, ma. Thank you, ma. Thank you, everybody. Thank you, Chineme. Thank you. We move to the next presenter. Dr. Oham Marianne, please. You can start sharing your slide. She's going to take question number 2.
Good morning, my seniors and my colleagues. So I'll be taking question number 2. Sorry. So practice question number 2. So station 2, can you hear me?
Yes, we can hear you.
Okay. A 63-year-old man, non-type 2 DM, hypertensive, BPH patient who was recently diagnosed with RVD and he was commenced on heart. He also complains of repeated dizziness associated with fall. Blood pressure was 230 over 130 millimeters of mercury, which later dropped to 160 over 100 millimeters of mercury. He is on lisinopril, nifedipine, metformin, and atorvastatin. Questions: what are the possible causes of dizziness? Which of the drug causes dizziness? How will you ensure drug compliance? With heart, what kind of drug? I saw anticipation, but I think that should be interaction. Are you anticipating? So for this index patients, the possible causes of dizziness include anemia, which could be due to the HIV or the side effects of the medication, because they said the dizziness was recurrent with associated falls. So I thought of anemia. Then heart-associated dizziness. Some medications, antiretroviral medications, cause dizziness, efavirenz, especially efavirenz and dolutegravir. It could be paroxysmal arrhythmia. It could be seizures due to hypertensive encephalopathy because the blood pressure was 230 over 130 millimeters of mercury. It could also be HIV-associated CNS infections. It could be alpha blocker associated dizziness and postural hypotension, because though we are not told that the patient is on alpha blocker, but he has BPH, so I don't know whether, okay, let's say possibility is that he's also on alpha blocker. HIV-associated autonomic neuropathy, which can cause postural hypotension, and peripheral neuropathy in HIV. Severe peripheral neuropathy can also cause falls. Then DM-associated autonomic neuropathy, because we are told that he has DM, and the peripheral neuropathy. HIV-associated accelerated aging. Normally, ideally, falls is not associated. That age, they shouldn't have the recurrent falls of geriatric age range, but because of HIV, there could be accelerated aging. This list is not exhaustive. I also thought of ricinopril-induced phase dose hypotension. That's but they said the cause, the falls, the dizziness was recurrent and with associated falls. So that's why I did not add it here. So which of the drugs cause dizziness? When I actually checked, most of those drugs they listed there can cause dizziness, especially with overdose. But why I chose efavirenz was because even though we are not told the particular heart the patient was on, but when I checked the guideline, efavirenz was dizziness was specifically written as a side effect of efavirenz. That's why I chose efavirenz. But all other medications, even the non-nucleoside reverse transcriptase inhibitors, all of them can cause dizziness. But because this one was clearly written as dizziness as the side effect, that was why I chose efavirenz. So how will you ensure compliance in these patients? Okay, before I answer that question, I just want to talk briefly on compliance and adherence. So compliance is the extent to which a patient's behavior matches the prescriber's advice. It implies patient obedience to the physician authority, whereas adherence signifies that the patient and physician collaborate to improve the patient's health by integrating the physician's medical opinion and the patient's lifestyle, values, and preferences for care. Adherence is the patient's behavior of taking drugs correctly based on mutual agreement between the patient and healthcare provider. It involves taking the right drugs at the right time, at the right dose, and at the right frequency, and at the right time. It is the degree to which the person's behavior corresponds with the agreed recommendations from healthcare provider. So what I'm trying to say in essence is that for our patients, we should be talking more of adherence and not compliance, because we want our patients to be want to educate our patients on why they should do what they should do, and not just the paternalistic approach to healthcare. Although when we are asked compliance, the things I listed for adherence can also go for compliance, but I think we should be talking more of adherence. So ensuring adherence, some of the things we can do is to provide information and education to clients or patients before initiation of ART or any medication at all. I wrote ART because I got this some of the points from the National HIV Guidelines. So it must not be ART, any medication at all that we are recommending for a patient. We should educate them on their conditions and the medications and the possible side effects of the medication they should expect. And then we should assess the understanding of the information provided. Provide information on the need for early initiation, involve patients in decision-making, highlight the importance of 100% compliance. Other ways of ensuring adherence: assess and address barriers to initiating medications or continuous adherence counseling. So we should keep counseling the patients anytime they come for follow-up. We should encourage them to continue adhering to their medications and other treatments recommended. Involvement of support system, maybe the relative, the husband, reminders and patient engagement tools or adherence improving aids like SMS text messages to remind them for their clinic visits or taking their medication. Encourage them to set alarms so that, especially the older ones, so that they will remember when to take their medication. They can mark their next visit on the calendar. They can use pill boxes and so on. So we should prevent and adequately manage adverse drug reaction. We should know about drug-drug interactions. And then we should also talk to the patient about possible side effects. Use of fixed dose combinations to reduce polypharmacy and drug with lower frequency dosing. So instead of giving TDS medication, we can choose the ones that can be given daily. Simplify medication taking, encourage participation in support groups to encourage patients more. Encourage and encourage behavioral support. Incorporate medication regimen into daily regimen or activities. For example, we can advise the patient that, okay, you can tie your medication to brushing your teeth in the morning. So after brushing your teeth in the morning, you should know that you should take, the next thing is to take your medication if it's something that doesn't need a meal or something. Or once you finish your breakfast, just before you take your breakfast, you take your meal, or once you finish your breakfast. So it should be tied to something so they will not forget. Schedule appropriate follow-up and assess adherence during follow-ups. So ways to monitor adherence. Viral load monitoring. This I got this one from the national guidelines. So that's this one is particular for HIV. Then other drugs, other ailments that we can monitor viral load, it can also be done for them. Then pharmacy refill records. So if a patient was supposed to come for refill in 2 months and the person comes back in 3 months, then that tells us that the patient does not adhere to the medications. Self-reporting, this is what the patient tells you. Then pill count in clinic. Electronic monitoring, this is a form of telemedicine where you use electronic to monitor whenever the bottle of the medication is opened. So this is telemedicine. Quantification of drug levels in body fluids. That's for drugs that can be measured in body fluid. So barriers to adherence. So it could be patient factor, treatment factor, clinical environment, patient-provider relationship. So patient factor, self-efficacy or beliefs in one's ability to succeed. Substance abuse, lack of social support, incarceration, pregnancy-related conditions, inability of patients to identify their medication, lack of support, lack of patient education, forgetfulness, stressful life events, self-stigmatization, health status. Example, severe illness, dementia, mental health. Treatment factors include drug toxicity, high pill burden, long duration of treatment, medication side effects. The clinical environment, distance to facility, poor quality of adherence, counseling, clinic staff attitude, cost of treatment, perceived benefit versus barriers. Example, discrimination and stigmatization, perceived lack of confidentiality, unpleasant past experience, long wait time, then patient-provider relationship, poor patient-caregiver relationship, lack of trust, poor conception of finance of clients' confidentiality, lack of empathy or one, poor communication skills, stigma and discrimination, lack of clients' openness or cooperation. So the last question, with heart, what drug interaction are you anticipating? So renal clearance of metformin, the dolutegravir inhibits organic cation transporter 2, sorry, not anion. So renal clearance of metformin occurs by glomerular filtration and active tubular secretion. And the active tubular secretion is mediated by organic cation transporter 2. Dolutegravir is an inhibitor of organic cation transporter 2. So it might increase plasma concentrations of drugs eliminated through organic cation transporter 2 pathway. Then again, calcium channel blockers are metabolized by cytochrome P450 with potential interaction with NNRT1 and protease inhibitors. Protease inhibitors inhibit cytochrome P450 and non-nucleoside reverse transcriptase inhibitors induce cytochrome P453A4. So the protease inhibitors, because they inhibit the cytochrome P450, they can increase concentration of calcium channel blocker. Why NNRTI reduce the bioavailability of calcium channel blockers. So thank you. That's the end of my presentation.
Thank you, Dr. Marianne. It's a very good one. Thank you very much. You've done justice to this topic. Thank you. I think the floor is open for comments and some additions. Thank you. I think I can start with my own. Okay, somebody, Dr. Dalhatu, go ahead.
Okay. Thank you, Dr. Mary Ann, for the presentation. It's a nice presentation. I learned a lot from the presentation. And thank you for actually, on a lighter note, trying to correct the examiners for sending the wrong question, adherence instead of compliance. What is in a lighter note? Okay, then the other thing that we consider how to ensure compliance or adherence patient on the medication, like you pointed out, efavirenz is being used and it usually causes dizziness, insomnia, and stuff like that. So how to ensure they comply to their adherence is most of them, they tend to take the medication in the morning. But the way to make it is to be at night. When somebody wants to go to bed, then he takes the medication. Before morning, the side effect of this dizziness and stuff like that must have went out. And the reverse is for the case of dolutegravir. Some patients, you know, we started using efavirenz, but subsequently we are now switching to dolutegravir. So the reverse case is for dolutegravir. Efavirenz causes insomnia, dizziness, and stuff like that. And that's why we encourage patients, somnolence, sorry, not insomnia, somnolence. And that's why we advise patients to take the medication at night so that once they take and then they sleep off, most of the side effects must have went before morning for the next activity. And for the dolutegravir, it causes insomnia. So therefore, we advise patients not to take the medication at night. Instead, they should take the medication in the morning. If they take that drug at night, so they tend to have insomnia at night, they don't have a very good sleep, and then in the morning, they will start manifesting, they are dizzy, and they are feeling like they want to sleep because they didn't sleep the last night. Then my other contribution is concerning, this patient is having diabetes mellitus. I think he's having hypertension as well. There are individuals that are at risk of having renal failure. So the patient with renal failure, we tend to switch them from tenofovir to abacavir. And we should remember, one of the side effects of abacavir, it can cause heart failure as well, and it has cardiac toxicity. So this is another point, because some of them, you will see that they migrate them to abacavir-based regimen instead of tenofovir-based regimen. So the abacavir-based regimen is problem with the cardiac interaction and cardiac toxicity. Thank you very much. It's a nice presentation.
Thank you, Dr. Dalhat. Thank you. Dr. Mary Ann is a very good one, actually. I just want to take us back on the possible causes of dizziness. I agree with you. It is an interactive. I don't think they may have one or two things that must be, because there are a lot of things that will cause dizziness in this patient. However, from our our chief is want to talk. So go ahead, sir.
Good morning, Dr. Yahya.
Good morning,
well done to the speaker, and well done, Dr. Dalhat. You actually solved one of the issues that I was going to. I don't think the question was recalled wrongly, and I don't think the examiners were wrong either. As the speaker had pointed out, of course, there's a difference between compliance and adherence. And adherence is on a higher level than compliance. Just like concordance is on a higher level than adherence. Then, of course, shared decision-making is at the end of the spectrum. Okay? So you would, in this particular scenario, we talked about ways you can improve compliance. Like the speaker said, in summary, what compliance basically is the patient following the doctor's instructions. Okay? So it's more of a passive type of thing, meaning that all you're doing is, doctor told me to do this and I'm doing it. Now, when a patient doesn't comply, it's because the instructions that have been given to the patient is difficult for the patient to carry out, or for some reason, the patient is unable to carry out those instructions. Usually because of side effects of the medication, pill load, things like that. So as Dr. Dahatu had pointed out, one way to improve compliance is how you prescribe. So yes, if you know the drug is going to cause dizziness, then give it at night. If you know the drug is going to cause insomnia, then give it after the person has woken up, so that the side effect is not felt immediately after the drug is taken. So you can match the drug in that way. That way, the patient can follow your instructions, which is what? Compliance. Okay? Other things you can do to ensure compliance is to give the person shorter appointments and don't give them too many medications at once, meaning that the quantity of medication you're giving. So maybe you only give 2 weeks or, something of the sort, so that the patient can quickly come back and give you a feedback on what's going on. Okay, so and that way you can keep an eye on whether the patient is following your instructions or not. Now, adherence is the next level when you start talking about, yes, the patient's lifestyle is now adjusted to fit the management plan of the doctor. So when the patient starts coming up with things like setting alarms, or when I take the drug, getting a drug bowl or drug container to separate the medications and time when the medication should be taken and things like that. Those are things that the patient have done actively to improve the fact that they need to take those drugs. So in other words, they are changing their lifestyle to fit that management. Okay? Concordance, on the other hand, is basically you and the doctor sitting down together to come up with how you would go about, following that management plan. Okay? So the doctor will tell you things like, the drug needs to be taken like this, with this particular type of meal or something. And the patient will say, oh, I don't eat that type of food and things like that, or I can't afford to eat that, or the drug is too expensive or something. Then the doctor now starts making changes to fit what the patient wants. Okay? And eventually you get you get a management plan that the patient can blend with. That is concordance. And then the final part is when you take shared decision making. That's when you and the patient sit down to come up with the management plan. It's not how to follow the management plan like you were doing in concordance, but you and the patient sit down to decide the management plan itself. Okay, so that is like the highest of all the forms of these scenarios. Yes, so I just wanted to point out that. So the question may not have been recalled wrong. They actually just wanted to test whether you knew the difference between compliance and adherence. Yes.
Thank you, sir, for that clarification. Thank you very much. Please, Dr. Marianne is a very good one. As I said, I just want to add 1 or 2 things from the long list of the possible cause of dizziness in this patient. From neurology thinking, as you highlighted, most of the common causes. Is a patient with 63-year-old that is a non-hypertensive diabetic with elevated blood pressure of 230, 130, and again come down with recurrent dizziness and fall. So one should think of vascular event, especially the posterior circulation stroke. It's one of the stroke that is notorious for just coming with dizziness. Though it should be very acute, but can progress to be recurrent like that. So I think on the lower down, one should think of that because of the multiple risk factors. Even the RVD is a risk factor for stroke. So posterior circulation stroke is a possibility. Another thing again that we should entertain neurologically is RVD-associated cerebellar disease. One of the commonest infections that affects cerebellum is retroviral disease. So, and again, patient is an elderly with other risk factors that can cause vascular events. So it could be that he has RVD-associated cerebellar disease. But I just want to think again, should we think of hypo or hyperglycemia, being him diabetic, elderly at that age, which will have caused dizziness in this patient? And I don't know whether, again, it's wise to think of down, benign paroxysmal positional vertigo, even though they did not tell us whether dizziness is associated with raising of head or doing some other things that raise his head or something like that. So these are my few additions. Thank you. By the way, it's a very good one. I think the floor is still open for our teachers and some and colleagues that want to contribute. Thank you.
Thank you, sir.
Good morning, sir. Please, I just want to clarify, well, not a clarification. I just want to ask the difference. I'm still trying to understand the difference between adherence and concordance. Please, if it's possible for it to be explained again.
Right. So with concordance, okay, adherence is, okay, you told the patient, okay, you need to make some lifestyle modifications, you need to take certain medications and all of that. And the patient, next time the patient comes to clinic, the patient doesn't just tell you, oh, I'm taking my drugs. They tell you how they are coming up with sorting all those issues out. Like now, you told the patient to exercise, okay? You told the patient, the type of exercise the person should do. But the person now tells you, oh, I like to do my walk in the evenings, or in the morning, I walk to walk. You know, you can see that his lifestyle is fitting that exercise. Same thing with his drugs. When they start telling you things like, oh, I time my drugs. Usually I put it by my breakfast table. So when I eat, I take my drugs so I don't forget, things like that. So that is more of adherence. The person is changing his lifestyle to follow your instructions. Do you understand? It has now become a lifestyle for him to follow your instruction. That is adherence. Concordance, on the other hand, is you've come up with a management plan for your patient. These are the drugs you're going to take. These are the measures we're going to take. These are the non-pharmacological measures we're going to take, and all of that. And you and the patient sit down to discuss these measures one by one. Okay? Where you would say, okay, you need to stop smoking. And the person says, oh, I can't stop smoking. I've been smoking forever. Can we do it gently? Okay, maybe I will reduce from a full pack to half a pack. Then I'll get to this point, then with this point, then we'll see where we go from there, right? That is more of concordance because two of you are sitting down to discuss it. You understand? You have not given instructions and the person is going to follow it, okay? In adherence, you've given instructions, the person is following it, but he's following it actively by changing his lifestyle, okay? But in concordance, the two of you are coming up with ways of making that management plan work. Okay, so that's why concordance can have positive concordance and negative concordance. Positive concordance is the person, it's moving productively. It's coming up with positive ways of dealing with issues. But negative concordance is something like, oh, you told the person to stop drinking. And the person says, oh, I've been drinking for all my life. I can't stop drinking now. Okay, that one cannot work. I have to continue drinking. I can reduce it small, but I'm not going to stop it. So that is negative concordance. But you as a doctor, you decide, okay, fine, let me not overstress this guy. Okay, let's leave him with his drink at this level. So both of you have decided that, okay, we're not going to take alcohol off the table completely. Do you understand? I hope I'm making some sense.
Yes, sir. Thank you so much, sir. It's clearer.
Okay, good.
Okay, there is another hand up. Please go ahead, sir. Maybe let me hand over to our teachers. Thank you, sir, for clarification.
Thank you, Dr. Yahya. Thank you so much. The first presenter, Dr. Agu, thank you. Dr. Maria, thank you so much. We appreciate both of you. All those that contributed, thank you. Teachers, Chief Chitu, Chief Koki, Manza, Remigos. I think I can see some of our new fellows in class. Thank you for coming to class. Please keep coming. We need your presence to help the new participants, those going for the next exam. They will really appreciate how the recent experiences are. So thank you for coming to class. We appreciate you. Then I just want to say that Dr. Yahya.
Yes, ma'am.
You know, I'm still having a funny relationship with Zoom. Please help me stop recording.
Okay, ma. Let me see if I.
You can. You are the host.
Yes, I stop, ma.